with herpes in pregnancy. Herpes is classified into three. There are three subgroups of herpes. One is localized, which is localized to skin, eye, mouth, and it constitutes 30% of the patients and has the best prognosis. Then with local CNS spread and disseminated. So disseminated one has the worst prognosis, and these two constitute about 70 the remaining 70%. Okay.
Okay.
Localized one has the best prognosis. Okay. So etiology. This is we are talking about genital herpes. So in India we say HSV2 is the major one which is responsible for genital herpes, right?
Yeah.
But then in UK, it has been seen that it is 50%, 50%. 50% by HSV1, 50% by HSV2. So both of them contribute to. Okay.
Okay.
And 75% as a result of direct contact with the infected maternal secretions. 25% cases due to postnatal infection. Okay. So majority are through direct contact through maternal circulation. And risks of acquiring herpes by the baby is maximum if the infection is in the third trimester, particularly within the 6 weeks. As viral shedding may persist and the baby is likely to be born before the development of protective maternal antibodies. And if it is during this time, the transmission is around 41%. So this question is asked, this percentage you have to remember. Okay. Even this has been asked like in SBS, which is correct like that. This statement has also been asked. So this one is important. This has been repeatedly asked. So primary herpes in the last trimester, particularly within 6 weeks, the chances of neonatal transmission is 41%. This you have to remember.
Okay.
Okay, so this is briefly about the management. So see, if it is primary, we'll start with recurrent herpes. So recurrent herpes is minor. Okay, so because already maternal antibodies are there, antibodies also cross the placenta, they protect the baby. So in those cases, the chances of transmission is only less than 3%. Okay.
Here the recurrence mean in pregnancy.
Yeah, pregnancy or any time before also. If she is got, she must be having the antibodies.
Okay. Okay. She'll be having antibodies. Okay.
Yeah. So in case it is recurrent, like the transmission risk is very low. So you will, in those cases, what will you do? You'll just treat the primary episode. How will you treat the primary episode? You'll give 400 mg acyclovir TID for 5 days. Okay. Then again, you'll because in order to decrease the shedding of the virus, you again give them acyclovir 400 mg TID from 36 weeks of the gestation, because it is also transmitted through sexual route, while the baby passes through the vaginal canal through the maternal secretion. 75% chances are there. So you have to give them suppressive prophylaxis starting from 36 weeks of pregnancy.
We continue until
Delivery.
okay.
Okay. And in these cases, you can offer vaginal delivery. In case like vaginal delivery, everything is fine, normal postnatal care. If there are active lesions at the time of delivery, then you just inform the neonatologist. They will observe for 24 hours, and after that, the baby will be kept under observation for 24 hours. After that, like after discharge, you will tell the parents about the warning sign. Nothing else has to be done. Okay. Similarly, if the primary herpes is in first and second trimester, where the transmission risk is low, because transmission is mostly during if the infection is during the third trimester. So this thing also you'll treat in the same way. You'll treat the primary infection and then suppressive prophylaxis from 36 weeks. You will offer vaginal delivery if everything is normal. There are no active lesions. Normal postnatal care. If there are active lesions, then you will keep the baby under observation. Inform the neonatologist and tell the patients about the warning signs when they have to come back. Okay. So this is how you treat. So this recurrent and primary herpes in first and second trimester management is almost the same. However, if the primary herpes is in the third trimester, where the neonatal transmission risk is as high as 41%, so there is 41% risk. So in these cases you have to treat. You will first treat the primary infection, and since it is in the third trimester only, you will continue this suppressive prophylaxis is till delivery, especially if it is within 6 weeks of the delivery. So you continue it. You do not stop it, and usually you will ask them if it is within 6 weeks. Ideally, you will inform the neonatologist, and patient should go for elective cesarean section.
Okay. If there is adequate time, she can go for a normal vaginal delivery. If it's beyond 6 weeks.
Beyond 6 weeks, or
If
sometimes the patient comes in active labor where you cannot wait for cesarean section. So yeah, ideally you will recommend for third trimester, you'll recommend cesarean. That will be the ideal management. Okay.
Okay.
Okay, and you'll inform the neonatologist. If the cesarean is there, then the baby will be under observation for 24 hours, and then after that, you will tell the patient's parents about the warning sign and discharge. If suppose in case the patient comes in in active labor, or you didn't know that the patient had herpes, she doesn't give the history, you get to know later on. So in those cases, what will you do? In case vaginal delivery occur, you will give first, you'll give IV acyclovir to the mother, 5 mg per kg every 8 hours, and also to the neonate, 20 mg per kg every 8 hours.
Okay.
Okay. And then you see after vaginal delivery whether the baby is well or non unwell. If the baby is unwell, then you have to do lumbar puncture for HSV, and and continue acyclovir for the baby while awaiting the results. In case the baby is well, then also you have to take swabs. You remember with the mnemonic score, so you take swab from the skin, conjunctiva, oropharynx, and rectum, and you send
Okay.
it for HSV PCR. So if the baby is well, you take swabs. If the baby is unwell, you do lumbar puncture. Okay.
Okay.
Both the cases you have to treat.
Okay.
Treat the mother, treat the baby with IV acyclovir here.
Okay.
The baby dose is higher than the mother. Okay.
And mother can breastfeed the baby.
Yes, mother can breastfeed the baby.